Thank you. I'd like to talk to you today about the role of bioethics to enhance teaching at the bedside with our residents. When I was first exposed to bioethics as a student, I found it to be a very detached, aloof kind of rule-based. I didn't see where it related to me as a medical student at all. Certainly didn't see where it related to the patients, but it was really because I just didn't have good ethics education. Later on in life, I had good mentors and professors, and I learned how important ethics really is and how important it can be at the bedside. So as faculty members, as teachers who are charged with training young physicians, there is a role for bioethics at the bedside, and we actually use it every day. So many of you will be familiar with the basic tenets, the 4 principles. These are the 4 pillars of bioethics. They were formulated in the late 70s, early 80s, mostly at Georgetown. But they serve as a sort of a stepping off point into the area of clinical ethics: autonomy, non-maleficence, beneficence, and justice. So they're all equal principles, but the one that's more equal than the others is autonomy. And this is really the driving force behind patients' rights movements in the 80s, and the basic tenet that patients have the right to decide what's going to be done to them. Respect for persons and for self-determination. And it is the major force behind bioethics today. Where we see autonomy play at the bedside with our trainees and our residents really is probably most often in the process of informed consent. Dr. Rokos will often tell us informed consent is not a piece of paper with a signature on it. That's just evidence that it took place. Informed consent is a process. And this is someplace we can really teach our residents what the bioethical principle of autonomy means. The patients need to be capable of understanding what we're going to say to them. They need to be willing to hear it. They need to be voluntary. We are required to give them the proper information that they need to make a proper decision or to make a decision. They have to understand in plain language what we're saying to them. And then they consent or don't consent. They either make a decision to proceed with what we are recommending or they don't. So this threshold information and consent process is really a bioethical tool, but we use it every day, every single day with patients for treatments and procedures. And it's important to teach our residents that this is really a bioethical process that's taking place. And a very important point to teach our residents, it is never ethically or legally, frankly, acceptable for a nurse to get informed consent for a procedure that's going to be performed by a physician. So it really is that exchange of information, that respect for patient rights and autonomy that drives informed consent. The other principles, of course, play into our everyday care of patients. Non-maleficence is basically do no harm. Whether it be non-treatment or abstaining from futile treatments, and very much comes into play during end-of-life decisions. Beneficence is do good. Do what's in the patient's best interest. And our residents learn from us by example. They see how we react and behave with patients, how we treat patients, and it's really our example that they follow, whether it's a good example or not. So the idea is to protect the patients, to prevent harm, to help people in need, to rescue people who are in trouble. And this is the principle of beneficence and the core of what we do as doctors. This beneficence autonomy interface can conflict, and it's under the general term of paternalism. Now, paternalism was the major force in medicine up until the 70s or 80s, when patients' rights started to become more important. The doctor told you what to do and you did it. Now the doctor tells you what they think you should do and you decide. There are rare instances where a patient's autonomy is eclipsed by their best interest. You can imagine patients' mental health issues, for example, emergency situations where patients' decisions may be overridden, but paternalism has sort of come to be a dirty word in medicine. But in some instances, it is something, and this is a very nuanced thing, and residents can only learn this distinction by following the good leadership, faculty leadership. Justice really pertains to allocation of resources, but justice itself was one of Plato's virtues. It's part of being a virtuous or moral person. But here in medicine, it's more about social justice, and we should encourage our residents to be active in the field. Medicine is changing rapidly, and we need physicians in the future that will guard for social justice. It's all about the doctor-patient relationship, and this has been termed an unavoidable trust. These patients are brought to us really in many instances through no choice of their own, and they immediately have to trust us. And we in turn have to bring empathy to the relationship and caring, and we are advocates for the patients. We're not just taking care of them, we're not just moving them through the system, hospital system. We are their best advocates. And similarly, I think we need to teach our residents and our students that are our charges that we're a family in medicine, and we also need to take care of each other. And it's a stressful career. Training is stressful for residents every year. Faculty members will encounter residents and students that are in moral distress because of what we do and the newness of it. And as the saying is, because the world is sick, I am sick. So when residents and students first exposed to patients, this can be a source of tremendous distress, and we need to support each other as well. When we do have ethical dilemmas, it's important to teach residents to use critical thinking, to be reflective about the situations that they've been presented with, and when need be, to call for consultation. There are ethics consultants in the hospital that can help them. You know, one of the things that comes with time, and we encourage with residents right from the beginning, is to have a reflective practice, to be cognizant of the lives that you're interchanging with, the trust that you've been given, the wonder of it all, of these people's lives and what we do every day and how privileged we are to be in their lives. The champion of all this bedside ethics was Edmund Pellegrino. An icon, passed away a few years ago, but a great biography if you ever have time to read about him. He's from New Jersey, started here actually as a chairman of medicine out in Hunterton, but he was an icon in bioethics, President's Commission in Bioethics, Georgetown, a real leader right from the beginning. A physician leader who really took on the role of a philosopher within medicine, and the whole concept of bringing bioethics to the bedside, the day-to-day interactions we have with patients and how we're really using bioethical principles and may not even know it, really comes from Edmund Pellegrino, who said the first principle of medical ethics, the end to which is directed, is the good of the patient. So for Pellegrino, maybe autonomy wasn't the most important of the principles, but beneficence was. So I think this is what we can teach our residents every day by our example and by our instruction. And bioethics really can be a very dynamic and important part of everyday care of patients. It doesn't have to be a detached and aloof discipline. So thank you for your time.